What testing will my doctor order to determine if my treatment is working?
So when someone starts a new treatment for their multiple myeloma, there's several different types of tests that one can monitor to see if the treatments are working. So typically when we're looking for response for the monoclonal protein or that abnormal protein that's produced by the plasma cells in multiple myeloma, one will order something called a protein electrophoresis. And this can be done in both the blood as well as the urine. And so monitoring how big that monoclonal protein spike is within the protein electrophoresis tells us a lot of information for response. There's also the free light chain levels that could be monitored. We look at both the absolute or the actual number of the free light chains that is elevated, as well as a ratio, because other things like, for example, kidney disease or kidney impairment can affect both free light chains, so that ratio is really important. So monitoring both is quite important. The protein electrophoresis as well as the free light chains are important to looking at response. And then, of course, depending on how one presented with multiple myeloma, so if one had high calcium levels or low red blood cell counts and anemia, or renal disease with high creatinine, we would want to monitor to see those kind of labs to see the responses for if your blood counts are getting better or if your kidney function is getting better. So another test that can be ordered is the quantitative immunoglobulins. And this isn't part of response criteria typically, but it also can be monitored for when one is responding. You'll see a decrease in these immunoglobulins as well if they were involved. So for example, if one has their abnormal protein is an IgG kappa or whatnot, one can monitor the IgG levels after receiving treatment to see how that has been decreasing as well. In rare cases, there can be non-secretory myeloma where that abnormal protein isn't demonstrated within the protein electrophoresis or the free light chain elevations, or even within the urine protein electrophoresis as well. And so in that case, it's a little harder to assess response, and really a bone marrow biopsy is your best bet. Seeing how involved your plasma cells are before the start of diagnosis compared to when one is being treated, the bone marrow involvement of your plasma cells could give a lot of information. If someone has what we call plasmacytomas or masses of the plasma cells as well, then that can be assessed with imaging. So whether it's a plasmacytoma that is outside of the bone or even just bony involvement of the myeloma, that could be monitored over time as well with imaging.
What is the IMWG's response criteria?
So when it comes to the response criteria of multiple myeloma, there are a lot of challenges, obviously, for patients to understand. In summary, it is basically showing how much of the myeloma that was there in the beginning of the total sum and mass of cells, how much has that been reduced. The least step that we can show is a 25% reduction. Usually what we measure is the monoclonal protein in serum and in urine. When you have 25% reduction or more, then we call it at least a minimal response. In patients who have a 50% reduction, we call it a partial response. In patients who have a 90% reduction, and it's a bit more complex than that, but in general we can say it, 90% reduction is a so-called very good partial remission. And if we cannot measure anything anymore in blood and urine with the most sensitive techniques that we have, then we call it a complete remission. To have this criteria, we also have to do a bone marrow biopsy and show that there's less than 5% plasma cells in the bone marrow. That would complete the complete remission definition. What we also have is a so-called stringent complete remission, where also the ratio of the light chains is negative, and in the immune histochemistry and from the bone marrow, we see that there are no monoclonal plasma cells left, so no cancerous cells left with microscopy. The next step is the minimal residual disease negativity, and there are also different levels, but the most important is to know that we use machines like either next generation sequencing or next generation flow cytometry, where we put a large number of cells, for example, 100,000 or 1 million cells, and if there is no myeloma cell in this 100,000 or 1 million cells, then we call it minimal residual disease negativity, and we also have to add what sensitivity did we use. And the last important factor is that we do imaging. We do usually PET-CT for follow-up, and we see if the PET-CT is negative, we call it imaging negative. And we know that if we do MRD assessment from the bone marrow, we also have to do an imaging because we might miss something, because the bone marrow biopsy is only one area where we do the biopsy. It is very representative, but it's not 100%. So it makes sense to do a bone marrow biopsy for MRD assessment plus an imaging. And if both is negative, we know the patients have a very good prognosis. And the last thing I want to mention is that some patients have kind of sequential MRD assessments from the bone marrow biopsies, for example, 6 or 12 months apart. And if they're both negative for MRD assessment, then we call it sustained MRD negativity. And in a lot of studies, we can see that patients with sustained MRD negativity have the best prognosis of all.
Are remission and response the same? What does it mean to be in remission?
Oftentimes confusion amongst patients, they are very surprised if they tell them they have achieved a remission. There's not really much of a difference between response and remission. Response is to therapy, remission is the remaining amount of myeloma, but the response basically leads to the remission. And I personally tell my patients, and it might be a little bit more philosophical than the research question, that even a partial remission is a remission, and even a minimal remission or minimal response is a remission. It is, of course, we want to achieve the deepest remission possible because that's the closest to a cure we can come. But I think even achieving a reduction, especially in later lines of treatment, it's helpful to achieve some kind of remission. And then there's even in clinical trials, sometimes there are clinical response rates or clinical benefit rates which show that a patient stays stable in a certain area. And patients who had a lot of lines of treatment, sometimes we are even happy to just keep them on a low level of disease that doesn't harm their body, and they can still survive longer.
The International Myeloma Working Group developed a standardized response criteria that is used worldwide. This chart summarizes the criteria needed for each level and response. The International Myeloma Working Group established this criteria in order to facilitate precise comparison of efficacy between new treatment strategies, and trials incorporate the serum-free light chain assay to include assessment of patients with oligosecretory and non-secretory disease, provide stricter definitions of CR, complete response, provide classifications that would improve detail and correct inconsistencies in prior response criteria. This criteria reconcile various previously used systems for assessing response and have been universally adopted. What is antibody interference?
There are a lot of nuances with our reliance on the protein levels and on the myeloma cells themselves. One, the proteins stick around for a while. I have many patients where their bone marrow is completely clear of myeloma, but the AMP spike is still stuck. It's not quite zero, it's 0.1 for months afterwards. Why is that? Because AMP spike is an antibody. Antibodies are designed to stick around for months. That can often happen where someone is still in a VGPR or a nearly a CR, but you still see a little bit of the antibody there, and that's okay. And that's completely okay, and I wouldn't change anything differently based on that alone. That's a limitation really of our IMWG response criteria more so than of our drugs. The other nuance to keep in mind about them that comes up quite a bit in the modern era of us using monoclonal antibodies as treatments is that the monoclonal antibody that's therapeutic can actually show up on the AMP spike. So this is confusing for patients, but I view it as somewhat poetic that the myeloma cells by definition produce this junk antibody, and we make a different antibody that looks just like it that attacks the myeloma back. So practically speaking, particularly for patients with IgG kappa myeloma, daratumumab, for example, Darzalex, is itself a monoclonal antibody. Just doing an SPEP, just taking your proteins and running them across an electrical gel, looking at what type of antibody and how big they are, it cannot tell what IgG kappa is from the myeloma versus from the daratumumab itself. Some of my patients may have an AMP spike of 0.1 for years and never quite be a complete response if they're on daratumumab maintenance, and that's okay. So I think at the end of the day, the response criteria are important from the blood work, but the IMWG appropriately also lets to look in the bone marrow. So if you do a bone marrow biopsy, that's really important. And so to confirm a complete response, a CR, which is my word for remission, to be in remission, really that bone marrow biopsy should be negative. the IMWG does have an additional criteria for patients in the bone marrow where you can assess for measurable residual disease. Those of you listening to this podcast, listening to this video, there are many resources on HealthTree about MRD. It's a constantly evolving topic, but you can within CR or within VGPR kind of say, look, is this MRD positive or is this MRD negative? And so that's another level of another layer of depth of response. That's maybe a story for another day.
What is a stringent complete response?
Stringent CR, trials use it. I think most of us in clinical practice aren't as preoccupied with it. So stringent complete response, within complete response was developed before the advent of free light chains being readily available. So basically a stringent CR would be that you're in a CR, so in a complete response, the bone marrow shows less than 5% of the abnormal cells, and the ratio of kappa to lambda is normal with the free light chains. I will say that when my patients are on clinical trials, it matters a lot because clinical trials go by the book of how IMWG response criteria are defined. In real life, as I'm alluding to, life is never that simple. In stringent CR, sometimes patients who have kidney disease, that can affect the normal ratio of kappa to lambda. So you may actually see that the kappa and lambda are not quite where they need to be. They never qualify as stringent CR and they're kind of stuck. In the modern era, I would say that for patients newly diagnosed today, VGPR, CR, and stringent CR all do relatively the same in my book because you've knocked out the myeloma cells enough, and any difference between some narrow difference with the M spike being 0.1 versus faint versus 0, or the free light chains being slightly off and therefore not a stringent CR versus being normal and therefore a CR is largely a function of our response criteria more than of the underlying myeloma disease biology. So I would say if you're looking at the video and you're like, man, I'm not in a stringent CR, just in a CR, fine. If you're looking at the video and I'm like, I'm only in a VGPR, I'm not in a CR, fine. I would say all those things in the modern era of therapy, patients like that will do excellently.
Is there a test that can distinguish antibody interference from therapy from the myeloma antibody?
So if you are interested, so I joke to patients that the lawyers go by the IMWG criteria by the book, and me I just kind of go with kind of a gestalt feeling of everything. But let's say if you're a lawyer inside, and you really want to know for sure, is this a CR or is it interference from the daratumumab that again can show up on the SPEP assay? There are tests that can do it. So there are drug-specific assays, something called HydroShift, that can help differentiate between how much of the M spike is from the daratumumab versus from the actual myeloma M spike. We also can run mass spectrometry. So we actually can do some fancy testing, something like kind of forensic science, basically, to actually look at the blood and see what's what. For example, the Mayo Clinic does have a test like that anyone in the country, their doctor can send their blood to. My caveat I would say to that is, again, when someone's M spike is 0.1 and their bone marrow is clear, I don't think it's going to change my management to know where that residual M spike is coming from. Because even if that's the myeloma, let's say we do it and I said that is the myeloma protein, the myeloma protein can stick around for 6 months, even when the bone marrow is negative and the protein itself is not the cancer. So I would say that yes, it is possible, and I have done it in certain situations, to go and try to differentiate what is the myeloma protein versus what is the actual therapeutic drug. But at the end of the day, if someone's M spike is 0.1, they're in a great spot. And if you do their bone marrow biopsy and they're negative, that's, in my mind, 1,000 times more important than what the blood is showing.